For the past decade, the goal of antidepressant treatment has been focused on remission of depressive symptoms. However, there's growing recognition of the need to redefine the treatment goal in depression, since remission alone does not necessarily translate into optimal patient functioning. This gap may result in patients suffering from continued impairment in different areas of their life, in particular, functioning at work. More recently, a paradigm shift is underway in the management of depression, with treatment goals now evolving towards ensuring that patients reach full functional recovery. How do physicians know when patients have reached functional recovery, or remission for that matter? Physician surveys suggest that both psychiatrists and general practitioners underutilize validated outcome rating scales in their routine clinical practice, despite evidence showing that they're an important component of optimized care. The main objective of this educational session is to review how clinical rating scales can be incorporated into routine clinical practice to improve patient care and outcomes. A special focus will be to introduce a new functional outcome rating scale, the Lam Employment Absence and Productivity Scale, or LEAPS. The clinical utility of this scale in managing working patients with depression will be demonstrated for initial assessment and for ongoing monitoring to assess how patients are functioning at work. This section will discuss the changing paradigm of how physicians assess patient outcomes in the clinical management of depression and how they can incorporate routine assessment of functional outcomes in daily practice without an unrealistic time burden. Evidence for treatment response has traditionally been the foundation for the approval of new antidepressants. Symptom rating scales, such as the Hamilton Depression Rating Scale for Depression, or the HAM-D, have been the gold standard for measuring patient response and remission. Typically, response is defined as an improvement of 50% or more from baseline using a validated depression rating scale. However, this level of response can still leave patients with considerable depressive symptoms that are associated with depressive relapse or recurrence. That's why guidelines currently recommend that, instead of response, patients should be treated to symptomatic remission. This is often defined as achieving a score on a validated rating scale that's within a normal range. For example, many clinical trials define remission as a HAM-D score of 8 or less. However, even patients achieving symptom remission may still have impairment in functioning. More recently, the outcome bar is being raised once again, with the ultimate goal for the treatment of depression now moving towards functional recovery, or the return of patients to pre-morbid levels of daily functioning, including work, social, and family domains. Why is functional recovery important for the working patient? While symptomatic improvement is an important component of recovery from depression, it describes how patients are feeling, but not necessarily how they are doing in their everyday lives. Functional recovery means the patient is once again able to function and assume responsibilities at work and at home, resume hobbies and personal interests, and restore personal relationships. This is particularly important in working people, since it's estimated that 7 out of 10 patients with depression are in the workforce. Pharmacotherapy remains the most studied and best evidence treatment for major depressive disorder. Clinical trials involving patients with depression typically measure symptom improvement, with treatment efficacy reported as symptom response and remission. All second-generation antidepressants, SSRIs, SNRIs, and newer agents, are recommended by the CANMAT guidelines as first-line medications. However, some of these have evidence for superiority over other first-line agents, as summarized in this table. Level 1 evidence is regarded as the best quality evidence. So, for example, escitalopram has good evidence for superiority over citalopram, duloxetine, paroxetine, and pooled SSRIs. Pooled SSRIs in this table refer to pooled analyses which usually included fluoxetine, paroxetine, and/or fluvoxamine, and did not include escitalopram. Similarly, sertraline has good evidence for superiority over fluoxetine and pooled SSRIs, while venlafaxine has good evidence for superiority over duloxetine, fluoxetine, and pooled SSRIs. Although there are small differences in efficacy and tolerability among the second-generation antidepressants, clinical variability among patients does not allow specific antidepressants to be recommended as first choice for every patient. This slide illustrates how it would be misleading to conclude that symptom remission always translates into functional outcome. In a 24-week head-to-head trial of escitalopram and duloxetine, the remission rates using a standard depression rating measure, the Montgomery-Åsberg Depression Rating Scale, or MADRS, were no different between agents. In contrast, using the validated Sheehan Disability Scale to measure functioning, patients receiving escitalopram had significantly greater improvement in the work domain compared with those receiving duloxetine. These findings underline the importance of measuring not only symptom outcomes describing how the patient is feeling in clinical studies, but also functional outcomes that describe how the patient is doing in their everyday life. Stigma remains an important barrier to patient disclosure of symptoms of mental illness. For patients, self-reporting scales may help them to disclose symptoms of depression and impairment that they may otherwise not voluntarily report or be able to verbalize. Using a rating scale to monitor progress can also be an important component of self-management, like using a home blood pressure monitor. For physicians, direct measurement of symptomatic and functional impairment may increase the likelihood of initiating appropriate treatment. For example, if there's significant impairment or distress, and may guide clinical decisions such as choice of treatment. Likewise, having a quick measure of functional impairment may help to assess treatment response. The Texas Medication Algorithm Project is an evaluation of algorithm-guided treatment compared with treatment as usual in a cohort of patients with clinically diagnosed major depressive disorder. A major component of the algorithm-guided management included regular assessment of treatment response using validated rating scales. In this study, all patients improved. However, patients receiving measurement-based care had significantly better symptom outcomes compared to those who received treatment as usual. The algorithm-guided care group benefited from a greater symptom reduction early in the course of treatment, which was maintained throughout the 12-month follow-up. While the study looked at a global management strategy and not specific elements of algorithm-guided care, it provides good evidence to support a treatment strategy that is founded on measurement-based assessment of depression outcomes. Now that we've made a case for targeting full functional recovery in patients with depression and the benefits of measurement-based care, this next section will illustrate how to incorporate a validated tool to assess work productivity that is simple and easy to use in clinical practice. The Lam Employment Absence and Productivity Scale, or LEAPS, provides important information into how patients are doing or functioning at work. This tool can help physicians make management decisions, such as whether or not a patient should stay at work, whether work functioning improves along with symptoms, and whether changes in treatment are needed to optimize work functioning. This chart shows the substantial impact of depression on work functioning. In this large survey of over 6,000 employees of 3 large American corporations, the odds of missed work, or absenteeism, due to health problems were twice as high for employees with depressive symptoms as for those without depressive symptoms. The odds of decreased productivity at work otherwise known as presenteeism, was 7 times as high. Both associations were highly statistically significant. The study authors concluded that depressive disorders in the workplace persist over time and have a major effect on work performance, most notably on presenteeism. Several validated scales to measure work productivity are available. However, none was specifically developed for assessing working patients with depression in a clinical setting. Furthermore, many existing work productivity scales were developed for research and usually are too long and complex to use in a busy practice. The LEAPS was designed to specifically meet these needs in the clinical practice setting. It is a 10-item self-rated scale that takes only 3 to 5 minutes for the patient to complete. It is simple and easy to use. Patients can complete the LEAPS in the waiting room or at home and can score it themselves. The items on the scale were chosen based on the symptoms that have the most impact on work productivity and the most common productivity problems experienced by patients with depression. The LEAPS was recently validated in a sample of 234 consecutive working patients meeting DSM-4 criteria for major depressive disorder attending a mood disorders outpatient clinic. Patients completed the LEAPS as part of their initial assessment. They also completed other validated rating scales, including the self-rated version of the Quick Inventory for Depressive Symptomatology, or QIDS-SR, and the Health and Work Performance Questionnaire, the HPQ. The LEAPS demonstrated high internal consistency and correlated well with all the comparator scales. Importantly, the LEAPS demonstrated good convergent validity with high correlations with the productivity subscale of the HPQ, which has been validated against objective measures of work functioning. Let's go through the various components of the LEAPS scale. You can follow along on the tear-off pad supplied with this video. The first 3 questions are general questions that ask the patient about the type of work they do, as well as how many hours they're expected to work to fulfill their responsibilities, compared to how many hours of work they missed over the past 2 weeks due to their symptoms. This serves as a helpful reminder for the physician about the patient's job and as a measure of absenteeism or time missed from work. The fourth question is broken down into 7 items that ask the patient more specifically about how their symptoms affected their work performance over the past 2 weeks. This question is answered using a 5-point Likert type rating scale, where 0 corresponds to none of the time, and 4 is all of the time. The patients circle the number that best corresponds to how their symptoms affected their energy or motivation levels at work, their concentration or memory, their anxiety or irritability, the amount of work they got done, the quality of their work, how many mistakes they made at work, and their relationships with coworkers. Scoring the LEAPS is simple. Each item score is added for a total score ranging between 0 and 28. This total score describes the patient's global work impairment. A score of 5 or less suggests no impairment or minimal impairment. 6 to 10 indicates mild work impairment. 11 to 16 is considered moderate impairment. 17 to 22 is severe impairment. And a score of 23 or greater is very severe work impairment. Going back to the LEAPS validation study, this chart shows how depressive symptoms affected specific components of work productivity in the sample of working patients with depression. Notice that in all measures of work productivity, the more severe the depressive symptoms, the higher was the percentage of patients experiencing clinically significant impairment. Another important finding from this study is that even in patients with mild depressive symptoms, a substantial percentage reported work impairment at least 50% of the time they were at work. This underscores the importance of routinely monitoring not only improvement in depressive symptoms, but also functional outcomes in working patients being treated for depression. So how can the LEAPS be used to guide clinical management of working patients with depression? Since the LEAPS is not a diagnostic tool, it should be used in conjunction with a symptom rating scale, such as the PHQ-9 or the Beck Depression Inventory. A key benefit of the LEAPS scale is that the total score can provide a quick measure of the degree of impairment in a patient's occupational functioning. The individual productivity items can also help guide treatment decisions, including whether it's appropriate and/or safe for the patient to remain at work, or whether the patient should take time off work. For example, a patient in a safety-sensitive job who endorses making more mistakes at work might benefit from workplace accommodation or a leave from work. The LEAPS can also help monitor changes in occupational functioning over time. By using a validated tool such as the LEAPS, clinicians can be assured they are monitoring functional outcomes in a standardized way. Furthermore, the LEAPS can serve as a useful charting tool to assess patient progress. The LEAPS total score provides a quick gauge of how the patient is functioning at work, which can save physicians time by eliminating the need to write notes describing how the patient is doing. Patients can fill in the LEAPS during follow-up visits, for example at 4-week intervals or as clinically appropriate. Ideally, improvements in work functioning should parallel improvements in symptoms. However, full functional recovery may take longer to achieve than symptomatic remission. Incorporating the LEAPS into clinical practice is not only easy to do, it can ultimately save you time by making assessment of your working patients with depression more efficient. Since the LEAPS is a self-rated scale, patients can complete the form prior to their visit. For example, the form can be distributed to patients when they check in at reception for their appointment, and they can fill it in either in the waiting room or in the examination room. As with other clinical tools, keep copies of the LEAPS in each examination room. This way, when patients report symptoms of depression, you can give them a copy of the LEAPS to complete while you attend to another patient. Or, give your working patients with depression a copy of the LEAPS to take home and ask them to complete it at home and bring it with them to the next follow-up visit. Incorporating validated clinical rating scales into routine practice can help deliver the best care to working patients with depression. The LEAPS is easy for patients to complete and score and can provide important insights into the impact of depressive symptoms on work productivity. The total score and individual work productivity item scores can help guide clinical management decisions and assess the patient's progression on the path to full functional recovery.